Okay, let's start with our first case. So no surprises what it's going to be. It's in the title. An elderly gentleman presents to hospital with a collapse. He says he's had lightheadedness on getting out of bed for nearly a year, and now he's also noticed some shortness of breath on exertion. On examination, his heart rate is 70 beats per minute, blood pressure of 100/87. Heart sound 1 is audible, heart sound 2 is quiet, and there is a soft ejection systolic murmur. Can I say that's quite a nice way of presenting that sentence? Yeah, it's not a bad way of presenting your heart sounds, because if you're presenting to a cardiologist, they hate hearing 1 + 2 + 0. That just means nothing. Heart sound 1 audible, heart sound 2 quiet, soft ejection systolic murmur. That's quite a nice way of presenting it. I'll show you another way of presenting the murmur later on when I'm later on in this talk, but that's quite nice. Come on. Key examination findings. In aortic stenosis, one of the key findings will be a hard to feel pulse, which is also known as a low volume pulse. That's literally what low volume means. You know that slow rising low volume pulse you keep reading about? Well, low volume just means that there's not a large volume of blood in each heartbeat. The stroke volume is low, so it's a hard to feel pulse. You must only ever feel for a pulse character, i.e. low volume, if you're feeling for that. You can only ever feel for that at a central artery. That has to be either the carotid or the brachial. And to be honest with you, most examiners will prefer if you just go for the carotid because it's a bit more classic. However, in practice, brachial artery is acceptable. I would always advise students go for the carotid because it's very hard for me as an examiner to miss you reaching for the neck in the corner of my vision while I'm looking down at a bit of paper ticking boxes for hand washing. If I miss you feeling for the central pulse, you might lose the mark for it. So it's just a matter of practicality that you might feel it's a bit better for you to just make it really clear you're feeling for a big central artery by going for the carotid artery. Classically, this pulse is described as slow rising. I think this is quite hard to feel in actual practice with your hands. And I'll tell you what that means, yeah? Very, very quickly, I'm going to draw something here now. If I was to put an arterial line into a patient, where you just stick a cannula effectively into someone's radial artery, you would find some kind of trace like this, or they might even have a dicrotic notch, right? They might have this kind of thing going on. So it'll be something like this. If you have someone with aortic stenosis, then you will get some kind of trace that looks like this. This is a pulse that's lower in volume, so it doesn't reach anywhere near as high. So there's a difference there, yeah? So that's a low volume pulse. Also, the peak is very delayed. In your artery, the peak comes kind of early, actually, between beats. However, in a patient with aortic stenosis, and this is why you actually have to you have to get a real feel for this over time. It takes a while to develop the skill to feel it with your fingers. And to be honest, if this is one heartbeat, if the patient's tachycardic, you will never feel this. You have to have them at a heart rate kind of under 80 for your fingers to be good enough to really pick this up. You're talking milliseconds here. So this delay, where is the mouse gone now? Excuse me. My mouse has disappeared. There it is. So this delay, how do I draw now? Here we go. Oops. Excuse me. This little delay here is hard to perceive with your fingertips. So yes, it's a slow rising pulse. Yes, it's low volume, but that delay is a little hard to perceive with your fingertips. So I don't really hold it against medical students if they don't mention slow rising. The examiner can ask you any other pulse characteristics you might expect, and you can say with AS you would expect a slow rising pulse. I just wouldn't make up signs in an exam. So if you think the patient has AS, just tell them exactly what findings you had and don't ever make up signs. I think you can get in real trouble if you start making up signs just because you think it should be there, but while you haven't felt it. I mean, I'll be honest with you, I'm a cardiologist and I can tell you, I don't think I can feel a slow rising pulse frequently. It's really hard to feel. This is not something that's straightforward. Another key finding in AS is a narrowing of the pulse pressure. By that, I mean that your systole minus diastole is quite narrowed. So your normal blood pressure is like 120/80 or 130/85 if you're going by the British guidelines, right? Like that's what we target. But in patients with severe aortic stenosis, your pulse pressure is narrowed. So remember that patient, if I go back to that little intro we had for this patient. 100/87 would be a narrowed pulse pressure. It's narrower than you would expect. And that narrowing of the pulse pressure is a key clinical feature for aortic stenosis. It's also a sign of severity, but I'll come back to that. Another key exam finding with AS is a prominent apex beat. Now, the actual term for that is this is a hyperdynamic apex beat. The other older term for this from the 80s is it's a heaving apex beat. Any of those terms are acceptable, and I would be completely happy with any student mentioning any of those. How do you know from your fingertips whether this is hyperdynamic or prominent or heaving or whatever the word is you want to use? Simple. You know when you feel your own apex beat, yeah? And presumably you're at home listening to me on a laptop or something. You can feel your own apex beat. They're quite hard to feel. I can give you a little tip here. Apex beats are slightly easier to feel if you ask the patient to breathe all the way out and just pause their breathing. In held expiration, when they're not moving their chest at all, the only thing that's moving is the heart and the lungs are empty of air. So the apex is a bit closer to the chest wall, so it's easier to feel that way. It only takes a couple of seconds. If you do that, you can localize the apex in most patients. But that's what a normal apex beat should feel like. In patients with severe AS or any kind of left ventricular hypertrophy, that's significant. You will find that the apex is so prominent, it almost lifts your hand off. It's got this great intensity of pressure behind it. And to be honest, once you feel it, you'll never forget it, because you will go through your medical life and find most apex beats are really tough to feel. Your COPD patients, your obese patients, those patients have very difficult apex beats to feel. But a patient with LVH, severe LVH, like in aortic stenosis, with severe aortic stenosis, those patients have a very prominent apex beat that can't really be missed. You find an ejection systolic murmur at the second interspace on the right side. You might also find that the murmur is there at the apex. How many people, and you don't have to have, I can't see your hands. Normally in a lecture theater, I'd say show of hands. How many people have been on a cardiology ward or a clinic and the consultant has said, this patient has AS, listen to the murmur, and you listen and you find it weirdly, you can hear the ejection systolic murmur at the apex, and it is louder there than it is at the aortic space. Everyone I know who's been on wards has had that experience. It's very, very classic to find that the AS murmur is louder at the apex than the aortic space. And that's because of a thing called Gallivardin's phenomenon. I can put the name for that in the chat if you really want to know what it is. Gallivardin's phenomenon is because of calcification of the aortic valve, and the calcium is metallic, so it reflects the pulse sound wave down into the apex, which is this nice cave-like shape. So it's a really well-recognized thing that actually the AS murmur radiates and is really audible at the apex. It's really, really classic because most people have calcific aortic stenosis. That's really, really common, and it's called Gallivardin's phenomenon. So that's a very common finding. You might find that the ejection systolic murmur radiates to the carotids. Radiation to the carotids is completely clinically irrelevant. So whether it radiates or not, it doesn't make any difference to severity of AS. So whether it's present or not is kind of by the by. You should listen for it because it's classic, but I have to say clinically, it doesn't actually portend anything specific. I mean, the only thing is if you've got a ejection systolic murmur and you're not sure whether it's pulmonary or aortic, and if it radiates to the carotids, you can be a bit more sure it's likely to be aortic, maybe. However, you could probably tell the difference by, breathing in, breathing out. Left-sided murmurs like aortic murmurs are going to be louder in expiration, whereas pulmonary murmurs, right-sided murmurs are louder in inspiration. Lex rin, left-sided in expiration, right-sided in inspiration. So to be honest, it's by the by. And you should mention it because it's kind of classic to mention it, but clinically it doesn't actually mean anything. The single most important thing, and I hate underlining anything on a slide, but I've underlined it here, the single most important clinical sign in AS, and this is clinically really important and important for your exams. Never forget this one, is loss of the second heart sound. Quietening or loss of the second heart sound is a key marker of severity. There are lots of markers of severity. Narrowing of the pulse pressure is a marker of severity. Prominent, but all of these are markers of severity. But quietening or loss of the second heart sound is one of the key markers. It really is a sign of critical severe AS, like it's very severe at that point. And it's important to note because if you find an ejection systolic murmur and you can still hear the second heart sound, you're pretty sure this is not critical. It's almost certainly not, right? It's actually a pretty useful marker to have in the back of your mind when you see someone in A&E or like a clinic and you can't get an echo straight away. That, okay, how severe do we think this is? If you can't hear the second heart sound, it's probably very severe. And that's why it's important to note. It's important to note because people with severe AS have a high risk of sudden death, and they need to be, we need to get on and refer them for surgery at some point. And finally, an example of a murmur. I'm going to open the chat here. Can you hear this murmur? Perfect. Okay, I'm going to close the chat now. Okay. Okay, murmurs are, I have to say, murmurs are generally quite poorly understood by everyone. I poorly understood them. I'll put my hands up and say, as a medical student, I struggle with murmurs quite a lot. It's ironic that I'm a cardiologist because I really struggle with quite a lot of cardiology. The thing about murmurs is you kind of need to be taught what pattern you're listening for before you listen for it. So you can't just go there blind. When you put your stethoscope on someone's chest, you kind of have to be thinking, okay, I'm specifically listening for heart sound 1, heart sound 2. I'm listening for the sound that goes whew, whew, or the sound that goes whew, whew. By the way, those two sounds, the first one, it goes whew, whew. That is ejection systolic murmur. That's a crescendo, decrescendo murmur that gets louder and quieter. And the second one where it just goes, that is a mitral regurgitation murmur because the sound pitch does not change at all throughout. And then there's other murmur patterns, which I'm going to go through. Specifically, I'm going to go through aortic regurgitation later today. So when you start listening for murmurs, I want you to try and get into the practice of thinking very actively with your stethoscope on the chest. Okay, can I hear heart sound 1? Yes or no? Can I hear heart sound 2? Yes or no? Okay, those are two key findings. Heart sound 1, audible, heart sound 2, audible. Those two things you need to present to the examiner. Then you need to think, can I hear the patterns of murmurs? And there's only 4 you need to know. There's AS, AR, MR, and MS. That's it. Like everything else is not really going to come up in a finals OSCE. We're not going to give you VSDs. It's really unlikely for us to do that. But a VSD will just sound like MR anyway, so it'll be the same kind of thing. So it's only 4 different patterns you need to listen for, okay? And the thing is, human ears are pretty good at this. You know how I know? If I was to hum you a Taylor Swift song, you would recognize it immediately. So you can recognize sound patterns pretty well. And you just need to know the 4 patterns of cardiac murmurs that exist that are relevant to your exams. That's it. You just need to learn those 4 and then think, okay, can I hear any of these 4? That's all you need to ask yourself. And those are your 4 murmurs. And everything else can go into the back of kind of the books until you become a cardiology registrar. Everything else can be by the by. Those are the only 4 clinically relevant and exam-focused things that you need to know. Listen again, and this time, listen for heart sound 1, listen for heart sound 2, and listen specifically for whew, whew, the sound that goes up and then down. I actually can't hear a second heart sound in this patient. I really can't. The lub is really subtle. I can just about hear lub at the beginning, but it might be better on my speakers because I've actually got the audio file and you're listening over the internet. So it's subtle, but I can hear it. It just goes lub really quietly. And to be honest, you're hearing something that someone's recorded through a stethoscope. So I'm sure the sound quality through your own stethoscope on a patient's chest is better. The lub is really there. I can't hear a dub. I hear lub and then no dub. Listen to yourselves after the end of this talk and put your stethoscope on your own chest in held expiration. There's no point listening to anyone's heart while they're breathing. That really is pointless. Like that's a silly exercise. If you put your stethoscope on anyone's chest to listen to heart sounds, you must ask them to hold their breath, either in inspiration or expiration, depending on which kind of murmurs you're listening for. If you're listening for left-sided, in expiration, right-sided, you listen in inspiration. So do that to yourself at the end of this talk, or whenever you have some time with the stethoscope, and you will notice a very clear, sharp, well-demarcated dub. And that second heart sound is always meant to sound crisp and quick and very sharp. And that's what it's meant to sound like. So have a listen to it later, and you'll notice that you couldn't hear this kind of thing where the dub is really kind of not there. Okay, I hope that's kind of clear. To be honest with you, this is always the most difficult bit teaching on Zoom, because in practice, I can actually bring like a medical student to the front and everyone can listen to his chest and kind of see the difference. All right. Key features in the history for aortic stenosis. Well, there are only 3 symptoms you need to know: angina, syncope, and shortness of breath. And the way to remember them is ASD, like atrial septal defect. That's the kind of, it's not quite a mnemonic, but that's the order of symptoms. That's the kind of aid memoir. It's very useful, ASD. And that's in worsening order of mortality. So if you ever get asked in an OSCE, could you give me some symptoms of a patient with a severe aortic stenosis or aortic stenosis symptoms? You can say the key symptoms in the history are angina, syncope, and dyspnea in worsening order of mortality. That's a beautiful kind of going for a prize top decile kind of answer, because you've given the three key symptoms and you've put them in the order that are clinically relevant. So patients with angina, half of them will be dead at 5 years. Patients with syncope, half will be dead at 3 years. Patients with shortness of breath, half will be dead in 2 years. So that's the worsening order of mortality, an increasing order of risk or decreasing order of mortality, whatever you want to call it. So those are the three symptoms that are relevant. Kind of makes sense, because if you've got severe AS, then one of the things you're having is that some of the blood coming out of the aortic valve is going to be in funny eddy currents, and it's not laminar flow, a nice smooth kind of blood flow. It might be worth me drawing this actually, just to kind of illustrate what I'm talking about. So if you have the aortic root, and you've got this tight aortic valve right here, yeah, it's really, really stenosed. Why don't I draw some kind of stenosis sign, right? Your coronary arteries come off here at the top of the aortic valve, excuse me. So if your coronary arteries are there and the blood coming through is coming off through this tiny little narrowing, and it's coming in this kind of blowing manner, and it's not nice, smooth, one-sided flow, then you've got this turbulent flow of blood, which may not go into the coronary arteries, and you can get angina symptoms with that, despite the fact that you don't have coronary artery disease. But you get angina because the flow down the coronary arteries is impaired, because the aortic valve just underneath the coronary arteries is so tight, and therefore the flow is turbulent, right? So you can get that symptom fairly early. Syncope is a bigger problem, because if you're getting syncope, that means that the blood is really struggling to come out to the point where this guy is, occasionally getting lightheaded or even collapsing, which means that that's a sign that this is really bloody tight. And that's a very key finding in patients with severe AS. Oops, where's my mouse now? Thing is, every time I draw the mouse disappears. Okay. And the dyspnea, shortness of breath, is a sign of heart failure. So if you're getting to heart failure, then the thing is this: if you start developing shortness of breath on exertion or at rest, then the mortality is higher than quite a lot of cancers. And if you have heart failure, it's pretty bad. Without treatment, the mortality is really high. So actually, if you have shortness of breath, then that's why your mortality is low, because at that point your muscle is failing. You can't supply your body with enough oxygenated blood, blah, blah, blah. So actually every organ system is starting to suffer at that stage. And one of the signs of that is shortness of breath. So that's why that's kind of lower down, and it's the most dangerous sign. At that stage, this is probably quite far gone. And the ventricle is now beginning to get really strained. Let me pull up one of the polls I have, because I think it's probably a good time to do it. You know what? No, I'm going to give you this slide, and then I'm going to give you a question at the end of this slide. Okay. This way I'm going to be fair. No one can say I'm being mean. All right. Understanding aortic stenosis. I really believe that if you understand this slide I'm going to tell you, you will understand all of cardiology. It really is kind of that simple. It really is just this one slide, and that's cardiology explained. Except for pacemakers, that's a whole separate thing. But the most of cardiology is here. Okay, most of it is here. Pacemakers are a kind of separate thing. We gotta go over that at some point. Come on, where's my mouse? Okay, perfect. I just want you to remember three things. In aortic stenosis, your aortic valve is getting tighter. Yeah, we'll just take it step by step. So this is normal. This is aortic stenosis. The valve is tight, right? Okay, everyone's with me so far. Number two, blood cannot get out of the ventricle because the aortic valve is tight, right? That's kind of the whole point of why the blood pressure is low, the pulse pressure is narrowed, all that stuff. The blood is struggling to get out of this ventricle because the outflow is obstructed. You've got a narrowed, tight aortic valve. The left ventricle therefore gets thicker because, well, let's take that step by step. The whole point of your entire biological system, your physiology, your cardiovascular system, by homeostasis, is to maintain your stroke volume and cardiac output. That's kind of the entire purpose of this whole thing, right? Your left ventricle is trying to force blood out of a tight aortic valve. Now, if I sent you to the gym and I said, right, just lift 10 kilograms with your bicep again and again, just do arm curls again and again, you will find, if I did that to you for several weeks, which is a very weird cardiac attachment you've had, that where your registrars asked you to do that, you will find that arm that you've been lifting weights with, the bicep has gotten bigger. At least that's what people who've been to the gym have told me. That's what happens, apparently, when you go to the gym. So that's happening because your muscle is working against a pressure. If your whole body is trying to generate about 120 systolic in the aorta to just kind of maintain adequate perfusion pressure in the kidneys, in the brain, in the liver, in every organ system, then to generate 120 here through a tight valve, it has to generate a much higher pressure in here. Does that make sense? It has to squeeze even harder, so to kind of keep this near 120. So the ELV has to basically keep squeezing harder and harder. It's contracting harder and harder and harder. The only way it'll manage to do that over time is by getting thicker, because it's just a muscle. The ventricle is just a muscle, so it'll just get thicker. So this wall gets thicker. That's why one of the key things you get in aortic stenosis is concentric left ventricular hypertrophy, and it is concentric all the way around because the whole ventricle has to contract harder and harder and harder. And with enough time, with enough kind of obstruction, your ventricle will get thicker. That's compensation. That's your myocardium just compensating for this kind of insult. Like, it's like, okay, I need to maintain 120. Fine, I'll just squeeze harder and it'll just compensate for a while. However, compensation can only last for so long. At some point that will fail and your blood pressure goes from 120 to 115. It drops to 110 with enough time. It keeps, it trickles down a little bit. The ventricle is like, it just cannot get any thicker. And this valve is just getting tighter and tighter with chronic degeneration. And therefore, at some point, this ventricle, as you're aging and the ventricle is aging, the architecture cannot modify any further. The blood pressure starts trickling down. At about 100 systolic or something, the patient finds that when they get straight up out of bed, they're getting a bit more dizzy than they used to. At about 90, they find that weirdly, they're getting dizzy spells during the day randomly. At 80, they're finding they are dizzy all the time or having blackouts. And then at that point, normally they pop into hospital. And they're also finding that when they kind of try running or exerting themselves, they're getting pretty breathless. All of that is a sign of worsening severe aortic stenosis. Does that make sense? That's how cardiac failure happens. Pretty much all of cardiology comes down to how your heart is modifying itself and its architecture to try and maintain your stroke volume and cardiac output. And that you can kind of, from first principles, work out everything that's going to happen once I give you the fact that this valve is getting tighter. Does that make sense? Well, I'm not looking at the chat, so I assume it makes sense. I keep asking questions that I can't hear the answer to. So I presume all of that makes sense. I'm going to carry on. If you have any questions about that, I will ask you. I will take them at the end, I promise. I'll be patiently taking questions at the end. I wanted to ask you a question here. Just give me one moment. Actually, guys, if it's okay with you, I'd like to ask you two questions. There is this, I'm doing kind of a survey just to kind of see what kind of people are coming to me. So just, would you answer this very quickly and I'll give you the proper AS question. I'm just very curious to see what kind of demographics I'm getting. Okay, I think I'll end it there. So, I mean, just out of interest, I can share this with you because it's all anonymous, isn't it? So let's just share that with you. Well, most people here are for finals. Basically, their medical finals are in this academic year. Fine, that's kind of makes sense. If you're here for clinical exams, like your first year clinical student, this may be a little bit advanced for you, but you're very welcome. To be completely honest, there's nothing here that you can't understand. So please feel free to stay, and everyone's welcome. Basically, I have enough Zoom space I've paid for, so I can have a few more students, even, to be honest. So the only other question I have to ask you at this point is this one. What additional sound, now that I've given you that information about aortic stenosis, what additional sound would you expect in AS patients? I'm going to give you not many seconds to deal with this, but I've just realized I'm just quickly looking at my Facebook because a lot of people are messaging, blah, blah, blah. I'm hoping everyone can join. One or two people saying they're struggling to join, but I have space for more students in this. I think I have space for more students in this. Do I have space for only 100? No, I think I can have more than that. Okay, and Paul, fine. All right. Okay, so let's share results. The thing is, the majority here are wrong, unfortunately. The third heart sound is something you're very unlikely to get with AS unless they are really kind of end stage about to die AS. The third heart sound is not the one you're likely to get. You're more likely to get a fourth heart sound. That's pretty common, and it's a sign of severe AS, actually. Opening snap, you won't get that here. That's a sign of mitral stenosis, where you get an opening snap. Venous hum is what you would get in a cirrhotic liver. Late diastolic murmur, you definitely won't get. It's an ejection systolic murmur. A late diastolic murmur is a sign of a regurgitant murmur of excuse me, excuse me, it's a sign of a mitral stenosis, excuse me. Whereas an aortic regurg, of course, is an early diastolic murmur. So you're not likely to get any of those. I'm going to stop sharing and explain why. I think the reason people went for third heart sound is I accidentally showed this slide and they saw third and thought that's what I'm going for. S3 is a sign of rapid ventricular filling. That's what the third heart sound is. It's rapid ventricular filling. Therefore, you are very likely to see this with MR. In most patients with clinically significant MR, they will have a S3 that's audible. S3 can be a normal variant. You can find this in young, healthy people running around. Yeah. And it may be completely normal. It's also a sign of heart failure, of course, and you can get that in late stage heart failure as well. It's a sign of rapid ventricular filling. That's why you get that sound. S4 is always pathological. This S3 can be normal, but S4 is always pathological. This murmur, excuse me, it's not a murmur, this added sound is very clearly a pathological issue. So you can never ignore an S4. And it's a sign of an atrial squeeze pushing open a non-compliant thickened ventricle. It is always abnormal. You can get this in hypertrophic obstructive cardiomyopathy and aortic stenosis. Just one moment, guys. I need a sip of coffee. Excuse me. Okay, fine. So we've already kind of covered, we've touched on a few of these, but signs of severity in AS include a slow rising low volume pulse, narrowing of the pulse pressure. Softening of the second heart sound is clinically the most useful sign because anyone with a stethoscope can pick that up pretty quickly. You don't even need skills for that. You just need to hear one and two. Can I hear both? If you can't hear two, that might be severe AS. Longer murmurs are generally worse. Longer murmurs are associated with severity. Fourth heart sound is associated with severity. You might get reverse splitting of the second heart sound. Of course, that's only if the S2 hasn't disappeared, and that can be a sign of severity. I'm going to discuss splitting of the heart sounds on my next slide, just to explain that properly. Signs of LVH are all signs of severity. So big apex beat, prominent heaving, hyperdynamic, whatever you want to call it, fourth heart sound, ECG, and echo criteria. So you can see ECG criteria for LVH. And of course, if you forget everything else in cardiology, you get to the OSCE and you're just kind of, deer in headlights moment where you just kind of like, oh God, I've forgotten everything Ritesh said. In any cardiac case, the ultimate sign of severity is congestive cardiac failure, right? Like that's it. If you're short of breath on exertion, then heart failure is the ultimate sign of severity. Because if your valves aren't working, if your ventricle isn't working, if you've got coronary artery disease, if you've got severe, very uncontrolled atrial fibrillation, the end point of all of that is heart failure. Okay. So at the end of all of these things, they all have a common terminal pathway, which is congestive cardiac failure. That's the sign of severity you can remember for anything in cardiology, pretty much. You can even use that for endocarditis technically, because of course there's septic shock, but ultimately, if the valve is ruptured and you're in septic shock, you will die of high output cardiac failure probably. So, that's the other thing. Okay. I put these next few slides in because over the years, quite a lot of people have told me that they really, really struggle with splitting of the heart sounds, that it's poorly understood and it's poorly explained. Can I give everyone a 2-minute break? Because I'm getting so many messages saying I can't join, which is worrying me because it's exactly 100 people. And I think my Zoom can take more. Could you just give me 2 seconds? I'm just going to pause sharing literally for 1 minute. Why don't you guys go grab a drink of water? Give me 1 minute because I want to just make sure that the Zoom is actually able to take more than 100. It kind of worries me because we've had like 200 people before, which is slightly odd. 1 second. I've just discovered the problem, which is the fact that basically there are too many people here. And I had a thing that let me have 500 users, but it expired yesterday. I just need to pay for that. Would you hang on for 1 minute? I'm just going to use my credit card and hopefully that'll let a few more people in here. Sorry about this, guys. Just 1 second. Okay, that seems to have worked. More people can join now. I'm just going to quickly message the events page to just tell them that. So if anyone is actually still hanging on, I do apologize for that. To be completely honest, I thought it was going to auto renew. So I do apologize, guys. Don't worry. This will just add like 2 or 3 minutes to the talk. I hope you don't mind bearing with me. Okay, sorry about that, guys. You know what? During the talk, I have to just mute like notifications and everything. So apologies if I didn't notice that. If you have any friends who've been kind of furiously trying to get to this talk, you can message them and say, try now, it should work. So apologies for that. It's now sorted. We should be able to have up to like a couple of 100 people or whatever the next level up is. Okay, so thank you for bearing with me. Let's just make sure everything is still working. Fine, perfect. So splitting of the heart sounds. Okay, I'm going to make this really easy for people. Splitting of the heart sounds is poorly understood by the vast majority of people. And it's actually doesn't need to be because it's quite a simple concept. Listen to the pulmonary area, first of all, on yourself later on, yeah? Just grab a stethoscope and listen to your own pulmonary area. Remember one rule in splitting of the heart sounds. Normally, the aortic valve closes before the pulmonary valve. That's normal physiology, that your aortic valve always closes before the pulmonary valve. The A goes before P, like in the alphabet, okay? So aortic first, then pulmonary. That's a fundamental rule to remember before I start talking any further. Okay. Now, it took me ages to make these little animations, so while they don't look impressive, we'll live with it. It took me ages. Okay. This is respiration. Oops, come on. There we go. All right. On inspiration, blood is being suctioned into the right atrium. When you take a deep breath in, you're creating a negative pressure inside the chest. It's the only way that you will get air into your lungs because you're creating a negative pressure because everything has to go down a pressure gradient. So if you want to fill your lungs with air, you have to breathe in and to breathe and therefore create a negative pressure by breathing in. So when you breathe in, the negative pressure in your chest will suck in air, but you will also suction in blood into the chest or mediastinum. And that blood, obviously, when you're coming towards the heart, goes into the right atrium, and these are the SVC and IVC I've drawn very crudely here. So your right atrial and therefore your right ventricular filling increases on inspiration. When you take a deep breath in, you fill those chambers more because you're bringing more blood to the heart, which ends up in the right atrium and therefore the right ventricle. If you take a deep breath in and blood enters the right atrium and right ventricle, you have a greater volume of blood on the right side than you did before. Your pulmonary valve will therefore stay open for a little bit longer. That delays your pulmonary valve closure. So by default, your aortic valve closes first. That's just the normal physiology. A goes before P. And if you take a deep breath in, you, as in like any normal person with normal heart sounds and all that, you will find that you increase the natural split of the second heart sound, the aortic and pulmonary sound closures, a little bit more on deep inspiration. So normal physiology is when you take a deep breath in, the split increases. That's normal physiology. It's quite subtle because you're hearing lub-dub. What you're really listening for is that the dub sound, the second heart sound, is split into two sounds. It goes da-da, really, really close to each other. I've exaggerated it there. We are talking milliseconds. You'd have to have a fairly slow heart rate, in the 60s or something or lower to really appreciate this. You can't hear this in a guy who's going 100 beats a minute or faster. You just really can't hear that. So in someone whose rate is controlled, you might be able to notice this. And you can hear that on deep inspiration in yourselves because you're young, healthy people, I presume. You will hear that on deep inspiration, you will find a slight increase in the split of the second heart sound. That's normal physiology. And that's because you are filling the right ventricle with more blood, and therefore you're delaying pulmonary valve closure. These two lines that are going back and forth, this white and blue line, the white line represents aortic component of the second heart sound, and the blue line represents pulmonary component of the second heart sound. So what can cause a wider split than normal? So a widely split second heart sound. Because I've just told you that your normal split is just a case of your pulmonary valve being delayed a little bit, anything that exaggerates that will make your split wider than normal. So anything that delays the pulmonary valve even more, which includes pulmonary hypertension or pulmonary stenosis. So either your pulmonary artery has such a high pressure inside it because of chronic lung disease or something that it delays the closure because there's not just volume, but the pressure is higher. So actually the closure of the valve, which requires the pressure to drop a little bit and go backwards, it's a little harder for it to do that. Pulmonary hypertension can cause a wide splitting of the second heart sound. Pulmonary stenosis because the valve just isn't moving so much. Or if the aortic valve closes a little bit earlier, i.e. this white line moves a little bit further to the left and closes even earlier, then you can get a wider than normal splitting of the second heart sound as well. And that's typically seen with mitral regurgitation. Because your heart's contracting, some of the blood ends up in the left atrium and the aortic valve closes even earlier because there's less volume of blood than normal. I hope that kind of makes sense. But you can listen to it again. If this recording is of decent quality, I'll put it up. You can listen to it again to understand that. This, where you've got the pulmonary valve closing first and the aortic valve closing second, is called reversing of the second heart sound, reverse splitting of the second heart sound. And that happens when you delay the aortic valve closure. And that's typically what you see with a tight aortic valve. If you have a very tight aortic valve, then the aortic valve kind of barely moves because it's calcific and tight and it doesn't want to move. And your aortic valve closes even later than normal, much later than normal. You will get a reversed splitting of the second heart sound. Because if you have this delayed closure, then the aortic valve doesn't close quickly, and then your aortic valve actually closes after the pulmonary valve, which is completely the reverse of normal physiology. Normally, the A goes before P. Here, the P is going before the A. And left bundle branch block can do the same kind of thing as well. You can also get the same thing with hypertrophic obstructive cardiomyopathy because of obstruction of blood flow coming out. Actually, while I'm here, let me try something. I don't know if you can see me. Okay, great. Oh shit. Excuse me. I share this computer with my partner, and they've clearly put some funny filter on there. This is not what I normally look like, obviously. I hope you can appreciate that. But Can I give you a little tip on closure, on splitting of the heart sounds? Normal is like this. We take a deep breath in, i.e. your hands spread up as you take a deep breath in. So the split is normally wider when you breathe in. And abnormal is just when you cross your hands and you go, and that's the reverse splitting. That's the easiest way to remember it if you ever forget, is just to put your hands together like you're praying. And when you breathe in, they separate out. So breathing in separates out the second heart sound. So normally on breathing in, your split gets wider. The reason I'm kind of going into this level of detail is that it's a pretty classic finals question for me to ask a very good candidate. What would happen to your heart sound, your second heart sound on deep breathing? Would it get, would you have a wider split or a narrower split? That's a pretty mean question. It's not pass fail. I'm going to stop the video because I look ridiculous. That it's not a normal split. It's not a normal kind of pass fail question, but it's a question I would ask if someone's really impressed me and I'm thinking, okay, this person could be referred for a prize or something here. And if they know answers to questions like that, then that's good and impressive. Okay, how do you manage aortic stenosis? Watchful waiting with repeat reviews kind of frequently, every 6 months to 12 months, depending on how severe you think it is, until they are symptomatic or severe on echo, or they get, basically until they get symptomatic or they have severe AS on echo. That's it. Those are the two things we look for. And finally, you give them an aortic valve replacement or a TAVI when it's necessary. Aortic valve replacement is open heart surgery. TAVI is transcatheter aortic valve implantation, and that's done either from a big femoral vein or sometimes it can be done apically. But generally speaking, we are doing them from, femoral vein, excuse me, from a femoral artery. Generally, we are doing them from big arteries in the leg, pretty much. It's done in interventional cardiology. For the ones who are really kind of going for the kind of top marks here, there's a lot of numbers you'll find in a lot of books, about, the 50 million, ejection fraction of 55% or less or blah, blah, blah. There's only one fundamental number that's really important. And this is the number I would recommend you remember. An echo gradient of greater than 50 millimeters of mercury across the aortic valve is severe. Now, the Americans and the Europeans and the British, every guideline is very slightly tinkering with this number every 2 or 3 years. Generally speaking, most cardiologists will agree above 50 is severe, yeah? Critical is like, above 100 or something, but severe is above 50, and that's all you really need to remember. The other thing to remember is that we will intervene on a valve if they are symptomatic, okay? So we will think about changing a valve when a patient is symptomatic, even if they only have moderate AS, if we are convinced that the valve is causing the symptoms. If a patient is coming to you and saying they cannot walk up a flight of stairs and they are limited in their daily activities because of a moderate to severe, it's like an ejection, it's like a gradient of 45, so they don't quite meet criteria, we would still consider replacing that valve. So symptoms are the single most important thing we work on. Then severity on echo is important, but symptoms are by far the most important. If the patient's completely asymptomatic and has severe AS, we would still recommend repairing it, but the urgency is a bit less. And if they develop left ventricular failure, i.e. the ejection fraction starts to drop, then we would also fix the valve. It's normally a very bad sign when that starts happening. The mortality goes up. In every patient who's having aortic valve surgery of any kind, any aortic valve surgery, we have to consider them for an angiogram first. Because these patients are elderly men generally they have coronary artery disease. So just because of the fact that they're men and they're older, so that's pretty common, and they all need an angiogram. So one of the things, if this patient in your clinic has, or whatever, in your exam has severe AS, one of the things you would consider is coronary imaging, particularly if you're thinking of referring them for valve replacement, because it's a key thing before they can have the valve replaced that they need a coronary angiogram. That can also sometimes be done by a CT scanning. So CT coronary angiography is often acceptable in most cases. The reason being, once you know they have coronary disease, you can offer them a bypass at the same time, and also it'll kind of guide their anesthetic risk. For the ones amongst you who are heading off to become anesthetists, if you need to kind of know that the patient having major cardiac surgery has a critical stenosis in one of his coronary arteries, right? It's kind of relevant to the risk of anesthesia. Okay, now this has taken a while, but it's worth it, I promise, because aortic regurg, I won't need to spend so much time because I've covered so much ancillary stuff around AS. You'll notice that I kind of use the overall topic AS and AR, but I kind of use them to try and teach you a little bit of medicine that touches on all of that stuff. So that's that I often find that's the most useful way of kind of remembering, because it's all linked. Everything is kind of linked to each other, to be honest. And if you really think about it, everything is kind of cardiology. It's pretty interesting. even colorectal surgery is cardiology, really, if you really think about it. Okay, how to present well. When you're presenting in front of an examiner, the things that look good, and I say this from my own experience in finals and as an examiner, I quite like it when the student uses the patient's name. It just kind of looks a bit more like less formal and less, you don't say this gentleman, you say, he gave you his name at the beginning. So you say Mr. Jones or whatever, like, I examined Mr. Jones's cardiovascular system. It just makes you look a little more human. So please use the name because it just looks better. I don't think the age is actually relevant. You can come in and check the name and date of birth and do all that stuff. It's important. But the age, the number of seconds you will spend subtracting 2022 or whatever from the act from 1947, don't waste your time. I'm not going to give you any more marks for that. It's not on the examiner's mark sheet at all. So I don't think this gentleman is 67 years of age or whatever is actually relevant. You examine Mr. Jones's cardiovascular system, just tell me what you found. Like, that's all I really care about. This is a very British thing. I don't know if they're doing this in Australia. I know there's some Australian students here, but I can't seem to get rid of this. Everyone keeps saying calm and comfortable at rest. It's a pointless statement, and it sounds very bizarre to me, because I presume that when you examine this patient, you did not tie them down and examine them against their will. I presume that they consented to it because you consented them at the beginning. So don't tell me they're calm and comfortable at rest. It's clinically irrelevant. All I care about on inspection, like the initial general inspection, is that the patient is well or unwell and they're tachypneic or not. So if the patient looks unwell to you and is breathless, that's all I really care about. So you can say, I examined Mr. Jones's cardiovascular system. At the end of the bed, at 45 degrees, he appears well and he is not short of breath, or he is not tachypneic. Boom, done. That's it. That's general inspection done. I'm happy. You can throw in something like, I did not notice any scars or whatever, if you want to go for extra. If you see a scar, you have to mention it. But if you don't see a scar, maybe it's a relevant negative. I'll leave that to you. Whatever you think sounds better. When you're presenting to an examiner, try not to use words like I think or I thought, because it makes me think you don't know what you're talking about. It's really unfair, I know. You can say, leave the same degree of ambiguity by using phrases like I feel or I felt. Consider this following statements, right? I think there's no clubbing, or I felt there was no clubbing. Both of them are just as ambiguous, but the I felt just sounds a little more certain of yourself. And it leaves the examiner thinking, okay, this is more of a, it just kind of, I don't even know what the right wording is to describe that. It's a little bit of a mental game. You're kind of just implanting the idea in the examiner, I'm a competent doctor. You will believe me when I say there is no clubbing. You're kind of implanting that idea. Whereas if you say, I think there's no murmur, or I felt there was no murmurs, you see the difference in just how it sounds. They're just as ambiguous as each other. But, I think, I feel there's a different way of kind of, it's a kind of impression you're giving to the examiner overall. When you're presenting, it's useful to practice a preamble to get rolling. Most people struggle with how do I start the presentation. Just practice 10 or 15 or 20 times, just starting off with rolling into the presentation. Mr. X is mildly dyspneic at rest with a respiratory rate of 20 breaths a minute, just as an example. The fingers are not clubbed. There are no peripheral stigmata endocarditis. The pulse is 64 beats per minute, regularly regular. Important to mention, if it's a cardiac station, that it's a regular pulse. Regularly regular is technically more accurate than just regular, but fine. And there is no radio delay. The JVP is seen as 3 centimeters, not elevated at 45 degrees. Just have some preamble that kind of, you can fill in the numbers and edit this, and depending on what your actual exam shows, but it's useful in finals. And I did this and I found it incredibly useful to write a preamble for most of the kind of top 5 cases I'm likely to get in gastro, neuro, cardiac, respiratory. If you write something like this down, it doesn't take long, and just practice it. And obviously you will edit this. You're kind of more familiar with how to articulate this stuff, and therefore you're not stumbling words around the examiner. It just looks more confident and it looks better. Sorry, all of this is just general stuff. We're going to get back to AS in a moment. With a murmur, you always want to time it. We've already done murmurs, so I can skip most of this stuff. To be honest, we already had a talk on murmurs, so you don't need this, but learn how to present a murmur and talk about it in inspiration, expiration, blah, blah, blah. Look, guys, I'm going to skip this slide because actually we had an entire talk on murmurs. I can come back to this at the end if someone's particularly keen on how I do this, but you know how to do murmurs. Okay. And at the end of the presentation, you need to say something generic. Everyone can use this. There are no signs of infective endocarditis or congestive cardiac failure. Those are the only 2 acute things or important clinical things that are relevant in terms of an overall impression. To complete my exam, I'd like to check the temperature, dipstick the urine, and request an ECG. You must be prepared to defend every one of those 3 things. Checking the temperature, endocarditis. Dipsticking the urine, because if they've got glucose in the urine, diabetes, cardiovascular risk factor. If they've got protein in the urine, then they could have either glomerulonephritis, which is a cardiovascular risk factor, or some kind of chronic kidney disease, cardiovascular risk factor, or you're looking for blood and protein in the urine, which can be associated with endocarditis. Requesting an ECG, well, I'd like to check that there's P waves for every QRS and make sure there's sinus rhythm. Just be prepared to defend anything you say I'd like to request. Try to avoid, I would like an X-ray. I really hated when medical students say, I'd like to do a chest X-ray, because why are you irradiating the patient who's just come to you for a cardiac exam? It makes no sense to me. So I would just avoid that entirely. You'll have some differentials, and you would, if you're a very good medical student, you'll tell me, I'd like to confirm my diagnosis with, and give me something like that. We're at 11:54. I hope you don't mind. We're going to run over by 15 minutes, I think. We're finishing 11:15-ish, if that's okay. Sorry, this is a congested talk, but we are aortic regurg is a lot shorter. I hope you don't mind, and I hope you've all had some caffeine. Okay, this is how I would present aortic stenosis. Okay, this is actually literally what I wrote for my finals, and this slide I have kind of copied and pasted since like 2009, because this is what I wrote to practice for my finals. You can write your own thing, your own words, whatever you think it will be easier for you to present. You don't have to be identical to this, is my point. Just write something down so you're prepared to practice with it. The carotid pulse is low volume and slow rising in character. This is after I've obviously started by saying Mr. Jones, blah, blah, blah. The apex speed is hyperdynamic. It's palpable in the fifth intercostal space and not displaced. Heart sound 1 is heard. The second heart sound is quiet. There's a ejection systolic murmur, you can say, of at least grade 4 severity, heard loudest over the aortic area and held expiration. That's how I present murmurs. I have a fundamental rule. If I can hear a murmur, then it's grade 4. That's it. That's all I've ever remembered for finals and beyond. That if I can hear it with my ears, it's probably grade 4. That's it. That's all you really need to know about this. So it's kind of useful because it means it's audible to you, and that's good enough. Then you get into the, oh, you can hear it across the room if you point the stethoscope at the guy. No, that's nonsense. Like grade 6 isn't a thing, really, realistically. Yeah, grade 4 means that most people can probably hear this thing. This radiates to the carotids. There are inspiratory creps in the lung bases, suggestive of pulmonary edema, but no sacral or peripheral edema. This gentleman has aortic stenosis with evidence of LVH. There are some signs of LV failure. I'd request an ECG to look for evidence of LV hypertrophy and an echocardiogram to confirm the valve lesion, assess the LV function, and consider investigations to look for coexisting ischemic heart disease. And then I kind of, I was really trying to be, I was one of those annoying people who's trying to impress the examiner. I hated myself at the time, but screw it, I did it anyway. He may be a candidate for aortic valve replacement. Vasodilators should be avoided as they will worsen flow across the valve and result in hypotension. Just a little kind of extra just to show him that, yeah, I know how to treat AS as well. So with AS, if it's severe, consider a valve replacement. And of course, this makes sense. This guy is probably having syncope all the time. You want to avoid vasodilators, right? And because that will just make everything worse and cause hypotension. Common stuff. Okay. What are the causes of AS? Most commonly, it's age-related degeneration if they're older. If they are under 50, 55, bicuspid aortic valve. With bicuspid aortic valve, they might have an ejection systolic click. That's more for your SBAs. Degenerative calcification is the kind of thing you'd get as you're older, and is because these are elderly men, you can get coronary artery disease with this. Rheumatic heart disease is fairly rare now. We just don't see it that much in the UK anymore, so it's not frequently seen. I mean, you can get rheumatic heart disease affecting any valve. The classic is MS, but it can technically do anything to any valve. So you can get AR, AS, MR, MS, anything with rheumatic heart disease, tricuspid stenosis, all that stuff. One super rare thing, and this is really, again, just for extra knowledge, is Williams syndrome. This is a inherited cause of AS. It's actually supravalvular stenosis. It's above the valve, but in practice, it's the same kind of thing because you've got this obstruction above the aortic valve. You might get the same kind of murmur, and patients have this thing called describes elfin facies, which is a dysmorphia that's just been given this name in classic textbooks, and that's Williams syndrome. It's also associated with sensory neurodeafness and hypercalcemia from my memory. Now, bicuspid aortic valve is important because actually something like 2% of the population have this. This is a very common thing you as a doctor will see in real life, like frequently. You may never see Williams syndrome, but you'll see this. Bicuspid aortic valve patients, as the name implies, they have 2 cusps instead of 3 on the aortic valve. and they are at risk of early aortic stenosis or aortic regurg or both. So they can have significant aortic valve problems and earlier than you would expect. AS in itself is a disease of the elderly. It gets more common with age. It's like atrial fibrillation. However, with bicuspid aortic valve disease, you can get severe AS before the age of 50, which is very unusual. And you should consider this in anyone who's relatively young with significant AS. That's really unusual, and those patients may well be bicuspid. And the reason to recognize that is that 5 to 10% of these patients have a coarctation of the aorta. Oh, crap. I had an SBA asking what was associated. It was coarctation. Sorry, I've ruined my own SBA. I completely forgot about that. Excuse me, guys. I had an SBA for that. Anyway, that was the SBA. That bicuspid AV is associated with coarctation. That's a very classic SBA. I was going to ask you that as well. Damn it. All right. Differentials of an ejection systolic murmur. There's actually not that many. You can say any systolic murmur, but specifically ejection systolic, where it goes, it's HOCM or aortic sclerosis. And then there's this classic question of how do you differentiate stenosis from sclerosis? I just made a slide that really nails this down. Stenosis means that the valve is narrowed. Sclerosis means that the valve is scarred. Yeah. So with stenosis and valve narrowing, you will get pulse changes, slow rising, low volume pulse. Apex speed changes. It'll get hyperdynamic because of that explanation I gave earlier of why the LV thickens up, and you'll get loss of the second heart sound. None of these will happen with aortic sclerosis, where you will just get the murmur, but you won't find any of the pulse and heart sound changes beyond that. So you'll hear lub, dub, but nothing, but you won't hear quietening of the second heart sound or anything else. I have to say, guys, just as an aside, most cardiologists do not believe aortic sclerosis is a diagnosis. This is really just mild AS. If you follow these patients up long enough, aortic sclerotic patients are going to end up with aortic stenosis. You just got to give it time. This is just early scarring, which will lead to degeneration and calcification and eventually narrowing. So older textbooks still have this, but in practice, in real life, this is not a diagnosis we ever write down in clinic letters. This is not a thing that we recognize. This is just mild AS, really. Okay. Patient number 2. And I promise you this is much faster. That is what Corrigan sign can look like, dancing carotids. I had to find this. I found it on a Facebook video, actually. As much as I hate Facebook, it was useful in this situation. Obviously, this is pretty dramatic, but you'll notice that the JVP tends to be kind of up here. I don't know if you can see my mouse, actually. Let me see if I can give annotation. Spotlight, what does that do? Oh, there we go. Okay, you might see that, hopefully. Okay, so the JVP should be kind of up here. This is kind of anterior to the sternocleidomastoid, and you can see that's, and the pulse, if you felt it, you'd feel a pulse there. That would tell you that this is a carotid as opposed to a, come on, go next, as opposed to a JVP. So clinical features of aortic regurgitation. Typically, patients have a very big, large volume pulse. And I say big because have a feel of your own carotids. Yeah, you can feel something pulsing in there. Don't press too hard. You need to stay awake for this talk. But if you feel it, you can feel something pulsing in there fairly easily. Patients with AR, when you put your fingers on their carotid pulse, the pulse really lifts your fingers off. It's a very big volume pulse. It's the opposite of aortic stenosis, obviously. Instead of being a small volume pulse, it's a big volume pulse, and that's typical. And the second thing with these pulses is that they are collapsing. Now, I'm going to try something different here. I'm going to use the video to try and explain how to feel for a collapsing pulse, because I've never done that before. Crap. I don't know how to get rid of this filter that my wife has put on here, but anyway, please bear with me. I do not look like that in real life, as I keep saying. You feel the pulse, right? You want to feel, I have to ignore my own face here. You want to feel the pulse, so your fingertips, it's hard because my hand is going the wrong way around, but you put your hand around the patient's wrist and your first and second fingertips are sitting on the radial artery. You feel the pulse with 2 or 3 fingers. You want to lift the arm up from the elbow. So your second hand goes underneath the elbow and lifts the arm up. I have seen something medical students do a few times, which looks really bizarre to me. They lift the arm up like really rapidly, and I don't know why that speed is important. You ask, obviously, if they have any pain in the shoulder, but the thing to do after that is lift it just gently. The speed is completely irrelevant. So gently lift the arm from the elbow. You don't want to lift from the wrist, because if you press too hard, you will obliterate the pulse. As you go above the level of the heart, you will find that the pulse disappears. And the reason for that is multifold. But one of them is the fact that your aortic valve is leaking. And if you go above the level of the heart, the pulse disappears because that column of blood goes straight back into the ventricle because of the leaking aortic valve. That's the collapse you're feeling for. So you gently lift the arm up. As soon as you go above the level of the heart, the pulse disappears. That's collapsed. In fact, that's basically it. You might find that the upstroke just gets much more prominently downwards. You'll feel it flicking against your fingertips, and this pulse is not sustained, and all of these things can happen as well. But ultimately, the pulse will disappear if you stretch the arm up. Then the second half of the test, which is the thing most people don't kind of do very well, but is a clinically useful thing, is if you take the hand down again, once you go below the level of the heart, that column of blood, which has been kind of distending the LV for a couple of heartbeats, will now come back out with greater force, and you'll have a bigger contraction. Because of Frank Starling's law, that the more you stretch the LV, the greater the force of contraction. For a couple of heartbeats, you'll have a bigger pulse once you bring the arm down. That's the second half of the test, and that's the water hammer effect. So those are actually two separate things. There's the collapse and the water hammer, and those are the two different things. I'm going to stop my video because I look ridiculous. I'm going to carry on. Okay, I hope that makes sense. That's a collapsing pulse. The other thing you're looking for is a widening of the pulse pressure, and that simply means the blood pressure will be 180 over 80 or something. So those two numbers are further apart. You're also looking for a big apex beat that's hyperdynamic, but also displaced. And you're looking for a diastolic murmur, an early diastolic murmur. Okay, remember what I said? When you listen for murmurs, you want to go there and actively listen for certain things. Here's what you're going to listen for. With aortic regurgitation, you're listening for heart sound 1, heart sound 2, and then you're hearing at the end of heart sound 2, instead of going lub-dub, the second heart sound is slurred. It goes dur. Instead of going lub-dub, it's lub-dur, lub-dur, lub-dur. That slurring of the second heart sound is the early diastolic murmur. Okay, I'm going to play you a decent example of that I found. Lub-dur, 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 lub-dur. That second heart sound sounds really abnormal to me. Like it's way too long and slurred. That's the bit. That's the diastolic murmur, and that's pretty key. Okay. Oops. Okay, there we go. And in practice, this is very similar to what I was discussing before. So let me just put up my little pointer. Okay. So 3 things to remember. The valve is leaking. So in diastole, the blood ends up back in the ventricle. So over time, this ventricle is receiving blood not just from the atrium, it's also receiving blood back in diastole. And therefore, it's filling with more blood volume than this one. Does that make sense? Yeah. This ventricle is getting blood from 2 sources as opposed to just the one, and therefore it needs to accommodate that blood, and it will dilate up. So one of the key findings in this is that the left ventricle dilates, it enlarges, and this becomes effectively it's a type of dilated cardiomyopathy, because this is a dilatation of the heart, and this is cardiomyopathy. It's a heart muscle pathology because of a leaking ventricle. Leaking aortic valve. Your LV compensates initially with LV enlargement, specifically dilatation. And for a while, it maintains your cardiac output. But you'll notice that the blood pressure is higher than normal, because obviously if you've got double the blood in here, then you will have double the blood in the aorta on every contraction, and therefore your systolic just goes up and up and up. And at the same time, because your diastolic depends on your aortic valve being patent, your diastolic pressure collapses, which is why one of the key findings in severe AR is that there is a widening of this pulse pressure. And for a while, your heart kind of manages, it compensates, and until it just can't compensate anymore. And then you get congestive cardiac failure, and that's the common terminal pathway of everything in cardiology. Other causes of collapsing pulse, it's a pretty classic finals question. It includes patent ductus arteriosus or AV fistula. AV fistula, obviously, you will see in patients with renal with renal dialysis. So that's pretty common. PDAs are pretty rare unless you're in pediatrics. Pregnancy can give you a collapsing pulse-like thing just because you've got a higher cardiac output than normal and you're more vasodilated. Anemia can do that because you're in high output. You've got a high cardiac output state. Fever, same kind of thing. Thyrotoxicosis, same kind of thing. There are some particular signs with aortic regurgitation that you need to be aware of. One is Quincke sign, which is nail bed capillary pulsations. Demusset sign, which is head nodding with systole. Abraham Lincoln classically supposedly had this. Abraham Lincoln apparently had Marfan's, and Marfan's is very strongly associated with aortic regurgitation. And because his head was nodding so much from AR, they noticed that in photographs, his face is slightly blurry. And people also noticed this in kind of old writings, that he was always nodding away during, no matter who was speaking, even someone he disagreed with, he would nod again and again. Which was supposed to be quite odd at the time. De Rosier's sign is a double murmur over the femoral artery. I remember that because do reminds me of double and just kind of a double murmur. Traub's sign is pistol shot femorals. You just have to remember that. Corrigan's is actually the most clinically useful one because you can see this at the end of the bed. All the other stuff is pretty rare. I've seen Quincke's once or twice. I've seen Corrigan's many, many, many times. That's dancing carotids. Hill sign is an important one because it's actually something that I've seen come up in exams before. So I've just put it here just because I have seen it in SBAs before, although I haven't personally written SBAs on it. Hill sign is a popliteal versus brachial cuff pressure difference of 20 millimeters of mercury. And it's a sign of severity in AR. And then this one just amuses me. Lighthouse sign is when your forehead goes red and white with each beat, which is kind of mean. And it's called lighthouse sign for obvious reasons, but it just amused me. Okay. Signs of severity in AR, well, ultimately, you can just say congestive cardiac failure, but widening of the pulse pressure, displaced apex are not good. In this one, shortening of the murmur is a classic sign. This is more of an MRCP question, so it might be a little advanced for finals, but I just thought I'd put it in for completeness sake. Shorter murmurs are associated with severity in AR, and that just means that if you have a huge leak across the valve, the murmur is short because the pressure equalizes very rapidly. So the murmur being shorter tells you that the leak is almost free flow, that there is no resistance to the blood going back into the ventricle. And that's why it's a sign of severity. Classic symptoms for AR, to be honest, there's only two. Shortness of breath, of course, with anything valvular, but angina as well. For similar reasons to what I said with AS. The interesting thing with angina is that for like 100 years, before we discovered coronary artery disease, was a pathology as a medical community. We weren't aware of coronary artery disease in the like early 1700s or whatever. Before it was discovered pathologically that coronary arteries could stenose and block off and you can get heart attacks, angina was thought to be just an aortic valve problem. Everyone who was having angina was just, once they died and they'd have autopsies, they'd find that the aortic valve was either leaking or tight. And that's because the blood coming out of the aortic valve, if it's turbulent, will not go into the coronary arteries very normally. The physiology is disturbed, and that can cause you to have angina despite not having coronary artery disease, which is quite interesting. So it's a very common thing. I want you to remember this because as a doctor in 5 years' time or whatever, you will see patients in GP surgeries or clinics or whatever, and or A&E, and they'll tell you, I'm getting chest pain on walking around. Yes, coronary artery disease is the commonest cause now, definitely. But don't forget that it could still be severe AS, severe AR, which means every patient with angina should really have an echocardiogram as well. You should listen to their chest and consider an echocardiogram because it may be coronary artery disease, yes, but they may also have significant aortic valve disease, as a cause of their symptoms. It's an important one to remember. Important one for history stations as well. Management of AR, if it's acute, i.e. sudden AR, it's just gone boom and the valve has ripped open, which is typically endocarditis. They need immediate surgery because they will die of heart failure. Otherwise, it really is something that you can't really sit on. The heart has had no chance to kind of equalize pressures and remodel itself. If it's happened just suddenly that the valve started leaking, they need emergency surgery. That's pretty typical for endocarditis. Chronic AR, where it's just kind of slowly getting worse because of degeneration, there are some medical options. For a while, you can try giving them ACE inhibitors or ARBs. Calcium channel blockers is a little bit in 1992, but yeah, it's still in the guideline. ACE inhibitors are kind of first line now. Afterload reduction reduces the pressure in the aortic root. And if you have a pressure of 120 instead of 180, then you will regurgitate less, right? So that's simply how it works. You just reduce the pressure so you have less regurgitation. You consider surgery, for similarly to AS, you consider surgery when the patient is symptomatic or they meet echo criteria for severity. And the key echo thing we're looking for is that the LV is just ballooning out and getting bigger and bigger and bigger. We look for the end systolic diameter of greater than 55. You don't need to remember that. It's a little bit extra. 50 millimeters of mercury for AS. I expect quite a few medical students to remember that, top decile people. This really is the prize winners who will remember this kind of thing because it's a little bit extra. I have tried to minimize numbers because I kind of still want one or two people in here listening to me to get prizes, but if I overload you with numbers, you will forget 20 other more useful things. So this is kind of it, but you will find more numbers in the books. Poor ventricular function, so drop in ejection fraction, which just means EF less than 50%, is left ventricular failure, is also an indication to consider surgery. Aortic root dilatation is a bad thing and is also an indication for surgery above 50. I've tried to keep the numbers as similar as I can. How are we doing in terms of time? It's now 14 past. We are like in the last 3 slides. So just bear with me, guys, and I promise we finish soonish. Thank you so much for hanging on. So, causes of aortic regurgitation. Well, your leaflets aren't working. So either you've destroyed them with endocarditis, or you were born with bicuspid aortic valve, which means the leaflets are abnormal and therefore they degenerate quicker than normal. So tricuspid will last longer than bicuspid, basically. Or you are just very hypertensive. If you have a blood pressure of 220 systolic, that aortic valve has to do a lot of work to try and prevent regurgitation. The pressure in the aortic root is the biggest problem. The other thing is your leaflets do work, but they can't meet in the middle, and that's because of aortic root dilatation. So your leaflets are physically fine, but they have been pushed apart because the aortic root has dilated for some reason. And there are many causes of aortic root dilatation. Typically, as a medic, we would think of aortitis, so some kind of inflammation of the aortic root. The classic used to be syphilis, and in SBAs from the 1980s, it would probably be Argyll-Robertson pupil, but that's not the case anymore. If I open the chat very quickly to indulge myself, can anyone tell me what's the commonest cause of an Argyll-Robertson pupil now? I can see a lot of questions. I promise I will come back to them at the end. What's the commonest cause? Yes, exactly, diabetes. So now if you see an Argyll-Robertson pupil, the number 1 cause is diabetes. But you go back to ancient times like 2002. No, that's much earlier than that. Like late 19th century, the commonest cause was syphilis. And tertiary syphilis could also be associated with neurosyphilis and aortitis, and specifically aortic root regurgitation. The commonest cause now probably is seronegative arthritis, and the classic for that is ANCSPOND. Around 4% of people with ankylosing spondylitis will have aortic regurgitation. By the way, if you suspect your patient has ANCSPOND, you can be really impressive in the exam and say, I'd like to take a history of lower back pain and listen to the lung apices, because they can get apical fibrosis. Just show off to the examiner how much you know, all that stuff. Connective tissue diseases, of course, can cause aortic regurgitation, and Marfan's is the commonest one of those. Ehlers-Danlos, there's others, but this is the commonest. And Abraham Lincoln potentially had this. The thing is, there's actually pretty good writing on this. Abraham Lincoln, on the day he was, I'll just give you a little story very quickly. Hopefully you won't forget it after this. Abraham Lincoln was going to see a play, which is where he was assassinated. And in the days leading up to that, there were quite a lot of reports that while he was walking around, he was quite breathless. He was getting some ankle swelling. He was just washed down and tired all the time. I suspect, I don't know for sure because we can't know for sure, but if he had Marfan's and he had democratise, then he probably had significant aortic regurgitation. And in the absence of ACE inhibitors and kind of proper treatment and changing the valve, he was getting worse and worse heart failure. He sounds like he had NYHA class 3 congestive cardiac failure. And the mortality rate without treatment of that is probably like 50% at 2 or 3 years. And it's a nasty way to die. I'm not excusing the assassination, of course, I must rush to add. I'm just saying that if he hadn't been shot to death, he probably would have died in a couple of years. Or been getting worse and worse heart failure. Again, I am not excusing Abraham Lincoln's assassination. I'm just saying that there's a medical point to be made there, and I hope you remember it. Okay, now before you run away, could you do me one big favor? This is the QR code to go to my page and leave a review. It's out of 5. At the end of this Zoom talk, you will receive a survey as well. This survey is very important to me. If you're finally a medical student, could you please fill this in? Because the survey, I am trying to source what kind of things come into your particular OSCEs, because I'm trying to tailor my final year revision course to that. So if you want to try and influence the course and kind of make sure your stations are captured definitely, then please fill in the survey. It really helps me out. And leave me a 5-star or whatever review out of 5 on this page. Please do spread the word about this. I'm sorry that my Zoom stopped more than 100 people coming in. And if you are seeing this on a video, hopefully the video got recorded, then I will put this up on my account on Facebook and Vimeo and YouTube. I'm now going to start going through the questions. So if you want to hang around, we will go through the questions. And actually, if you want to really hang around for another 15 minutes, I have 2 more SBAs which are relevant to aortic stenosis. But if you want to go away and have some fun, you can do that. It looks like rubbish weather outside where I'm sitting, but it's completely up to you. Let's go through questions, and I'm going to do 2 more SBAs for anyone who's actually interested in that stuff. Okay. Fine. Okay. Let's see now. Was wondering what you. Okay. Why